Thank you, Dan, for that very kind and undeserved introduction. I must say that I'm glad that my family is not in the audience when Dr. Sato presented that gargoyle picture of me. I haven't seen the picture for a long, long time. I thought it was buried somewhere. But to be honest, I'm very honored and immensely humbled by the selection as this year's inductee into the Doheny Society of Scholars, and to be inducted into the list of august prior recipients is indeed a capstone in my career. So thank you so much, and I know I pity the selection committee for digging deep into the bottom of the barrel to find me, but thank you for pulling me out. So what I like to do is to share with you. First is that I don't have any financial disclosure at all, but I will discuss an off-label and experimental drug use of a drug later on. I do want to say that this society was named after, started by Steve Ryan, and I was one of his residents in the first group of residents that he selected. So it's an honor for me to present in his honor. Steve Ryan is indeed a visionary, a leader, and an optimist who guided Doheny to its present place as a premier center for eye care and research. He's a model of integrity and professionalism. He's a brilliant clinician with an unwavering devotion to clinical research and resident education. I must say that he's an educator par excellence. So in sum, that I would consider him as an exemplar of a model academician that everyone should look to him for guidance. It's in the spirit of Steve Ryan's teaching of constantly looking for new ways to improve patient care that I'd like to share with you 3 of the enigmatic problems in which effective therapy remains elusive. One is adenoid cystic carcinoma of the lacrimal gland. I will share with you a new paradigm in treatment for this cancer, and that's intraarterial chemotherapy with a globe-sparing surgery using the intraarterial chemotherapy as a core element of this treatment paradigm. And then share with you my research interest in traumatic optic neuropathy, and share with you a new animal model, and to enlighten the molecular and cellular events in this traumatic experimental traumatic optic neuropathy animal model. And then finally, I'll share with you something that I am very passionate about for patients wearing prosthesis after exoneration, particularly in the third world country, in which they have no access to quality prosthesis, that this is a new way of addressing a need in the third world country, and that is a 3D printing for orbital prosthesis. So adenoid cystic carcinoma is a rare and devastating disease of the orbit. It confers worse prognosis among malignant lacrimal gland tumors. And the conventional treatment for this devastating cancer is either globe sparing, tumor resection, exoneration, or radiation alone. But most of the orbital specialists would subscribe to a combination of exoneration plus or minus adjacent bone removal followed by adjuvant radiation therapy. Despite various permutations of the conventional therapies, the prognosis remains grim. You can see this in the actuarial survival rate, less than 50% survive at the end of 5 years, and worse yet, at 10 years, only 20% may remain disease-free. This is the tumors associated with high local recurrence with this condition. The difficulty in achieving a long-term disease-free survival in this condition is in part due to the complex regional orbital anatomy, the aggressive biological behavior that's characterized by infiltrative tumor growth. There's a propensity for perineural infiltration, hematogenous and lymphatic spread, and then retrograde intracranial extension via the lacrimal nerve, which is a principal cause of death in many of these patients. Here's a case that illustrates that biological behavior. It's a young patient that I saw when I was a fellow at Iowa, presenting with a fullness of the region of the lacrimal gland on the right side, and on the imaging study you can see an enlarged lacrimal gland. Biopsy disclosed the typical pattern of adenoid cystic carcinoma, and then exhibiting another poor histologic prognosis, that is the presence of a perineural invasion. So recognizing one of the feature of this tumor is a retrograde extension through the lacrimal artery. So we put this patient then underwent the standard conventional therapy, and that's exoneration. At the time of exoneration, you can see that she has a pitting of the bone. It's a poor clinical sign indicating that the tumor has now marched onto the adjacent tissue, invading in the bone. It's aggressive behavior of this tumor. She underwent the standard exoneration with removal of the adjacent bone, and the socket was then resurfaced by a skin graft. Recognizing one of the features of this tumor is a retrograde extension into the brain through the lacrimal nerve. We put the area in the apex of the orbit, particularly in the superior orbital fissure, under surveillance, and clearly within a year or so, there's an area of non-healing ulcer in the orbital side, and on imaging study, we show that there is evidence of intracranial extension through the superior orbital fissure. You can see the intracranial involvement there. So it fulfills the biological pattern of this aggressive behavior, and the biopsy of the apex discloses to be indeed a recurrent adenoid cystic carcinoma of the lacrimal gland. Then we went in along with a neurosurgeon to perform a more aggressive surgery and resecting the entire apex, both from the intracranial approach and as well as from the orbital approach. You can see that we're rotating a pericranial flap to seal this opening and put a skin graft on top to separate the orbital side from the intracranial side. And so after many similar cases in which we have done everything we can for the patient, and only to complicated by the fact that the patient will succumb to the disease, particularly metastatic disease to the liver. So I developed a personal perspective after the fellowship that adenoid cystic carcinoma of the lacrimal gland is not a local disease. It is a systemic disease, and we need to treat it as such. We are missing something in the way that we are treating this with radical surgery locally. And my personal perspective is that the conventional exoneration and local radiation is a form of Halsted's original dictum in radical mastectomy for breast cancer. That is, cutting more equals living more. And so the dogma that cutting more orbital tissues in adenoid cystic carcinoma of the lacrimal gland equals living more is not always true, as illustrated by the example that I showed you earlier. So with advancements in cancer oncology, we can perhaps adopt a more nuanced treatment strategy and try to improve patient care in this tumor in here. So when I joined the faculty of vascular oncology, he's one of the first patients show up, young patient with a lacrimal gland mass. You can see at the time of presentation, the patient's already presented with intracranial extension of the tumor. So if I were to use the same technique I did for the other patient or patients, radical exoneration and radiation, he's not going to live more than 5 years because of the intracranial extension already. Recognizing this fruitless to try to repeat the same thing over and over again and expect a different outcome, I began to try something new and try to convince my medical oncologist to do something that they had never done before. And that is to put a catheter into the internal carotid and perfuse the lacrimal artery. The reason this is a good approach is because the lacrimal gland is subserved by a single artery, one vein coming back. So if you can cannulate the lacrimal artery, either by the internal carotid or the external carotid, we can perfuse a high concentration of chemotherapy to overcome the resistance of the cancer. So at least that's the concept at the beginning, utilizing the unique anatomy of the lacrimal gland. And so instead of internal carotid perfusion because of the fear cerebral complication, we instead use the external carotid, which has branches that will connect directly into the lacrimal artery. So that's what we have been doing, and cannulate the external carotid all the way up to the internal maxillary artery, and then begin to perfuse a high concentration of chemotherapy. The dosage for which, if you give it IV, would be very, very toxic to the patient. But because we're perfusing it intraarterially, the medication goes into the tumor, absorbed by the cancer, and then on the way out, the venous concentration is relatively low, and the patient can tolerate very well. So here's this patient that on your left is the pre-IACC, intra-arterial cytoreductive chemotherapy. And after 2 cycles, you can see that the intracranial compartment, the component of the intracranial lesion, has now shrunken into the orbit, for which exoneration can hopefully achieve a tumor margin-free clearance. And here's a coronal view showing pre-IACC, and then after 2 cycles of intraarterial chemotherapy, indicating there's indeed a shrinkage of the peripheral margin of the tumor into the orbital compartment, so that the aim is to get a margin-free clearance with exoneration. He then underwent a standard exoneration, and following the hematologic recovery, we then perform a standard exoneration. And following exoneration and healing of the socket, patient then receives standard adjuvant radiation therapy, but also get additional cycles of IV intravenous, not intraarterial now, intravenous cisplatin as a sensitizer during radiation, as well as 4 additional cycles of IV cisplatin and adriamycin. The reason you use 6 cycles of chemotherapy is that the biology tells us that in the solid tumor has 10 to the 20 number of cells, and each cycle would give a 2 log unit of kill of cancer cells. So after 6 cycles, the 10 to the 12 powers of cancer cell would essentially be 0 or 1 cell left behind. So that's the principle that we borrow from treating MOP therapy for other cancers. So in 2013, we reported a long-term follow-up of this series of patients. We collected 19 consecutive patients. We developed into 2 groups. Group 1 has 8 patients in which they present to us with intact lacrimal artery. No surgery was done other than the biopsy. In Group 2, of 11 patients, they were referred to us after the tumor mass was removed for presumed pleomorphic adenoma, and then realizing after removing it, it turns out to be adenoid cystic carcinoma. So in this group, they don't have really an intact lacrimal artery to optimally utilize this strategy. But we had 8 patients in Group 1 that presented to us with an intact lacrimal artery. So the survival statistic is that the cumulative 10-year disease-free, this is local disease control, as well as the total body disease-free. Survival is 100% in the 8 patients that we treated. And the longest survivor is the very first patient I treated. He's now still alive, disease-free, 27 years later. And this is what he looks like 27 years later after the treatment. The Group 2 patients, 11 patients, the cumulative survival is 72%. There were 8 patients disease-free, and the median survival is 7 years. And there are 3 patients not disease-free. 2 of them died of as a direct result of the adenoid cystic carcinoma with intracranial extension, as well as metastatic lung disease. And 1 patient has a metastatic lung disease, but is still alive and has local disease control. If you look at the Kaplan-Meier survival curve of cause-specific mortality, you can see this is a Group 1 patient This is the group 2 patient. In comparison to the historical data, you can see the survival rate for disease-free is much better. So in view of this salutary outcome of this group of patient treated with intraarterial chemotherapy, I now embark upon a new treatment strategy, and that is to give intraarterial chemotherapy as a core of this strategy. But instead of exoneration, we take the tumor out. It's a globe-sparing procedure, but using the intraarterial chemotherapy as a neoadjuvant modality to shrink the tumor down and hopefully get the margins clear so that we can resect the tumor. The aim is to have a disease-free survival, to preserve the eye, but more importantly, to preserve vision. So this is a new treatment paradigm that we're using now, and the protocol is as follows. You'll have the neoadjuvant IACC 2 cycles, followed by en bloc tumor resection, and this is what the patient looks like before IACC, and after 2 cycles, you can see a noticeable cytoreduction of the tumor mass. The aim in here is to reduce the tumor so that you can get around the margins and hopefully get cancer-free resection in here. It's not meant to completely remove or reduce the tumor mass by this modality. Then the patient undergo globe-sparing lacrimal gland removal. You can see at the time of surgery, the entire mass is resected, the orbital lobe, as well as the palpebral lobe. It's important to remove the palpebral lobe as well because the tissue has been programmed to undergo metastatic, mutation. So you don't want to leave any tumor cells behind. And it's fortunate that we do that because in post tumor removal, in examining the specimens, many of the cancer cells are also in the palpebral lobe as well. So if you just remove the orbital lobe, you are really asking for recurrence from the palpebral lobe later on. And this is a pre-resection compared to the post-resection. You can see this is globe-sparing. The tumor has been removed, and the bone has returned to its original place. The key in here is what can we learn about this tumor by taking the specimen from the bedside to the bench to understand the molecular underpinning of this disease that makes it so aggressive and so difficult to treat. And hopefully the information gathered in the laboratory can then be taken back to the bedside and use it. And I will share with you what we have done, what we have learned, how we have identified areas of attacking this cancer. And so what we have done is that we developed a precision orbital oncology toolbox and to specifically look at the mass that was removed in the globe-sparing strategy, mainly to assess the tumoricidal effect of the IACC-based globe-sparing strategy. The key is, does this chemotherapy work? Does this high concentration of cisplatin perfused through the lacrimal artery helpful in killing the cancer cell? That's a basic question that we want to answer. And we want to have a personalized evaluation of the patient-specific lacrimal gland molecular drivers of the cancer cell proliferation. We want to look at individual patients and what makes this tumor behaving in this way. There must be some unique mutations that's driving this cancer. We want to individualize the identification. And more importantly, to identify molecular clues to explain the microscopic metastasis or prevent metastasis. I'll look at biomarkers that will presage the metastatic disease later on. And then, based on that information, we will tailor our adjuvant therapy specifically to block the molecular drivers of the cancer cells in here. So tool number one that we use is the apoptotic marker. There are 5 markers that we use, but I will share with you the utility of one of the markers, and that is the tunnel assay. The aim in here is to assess the tumoricidal effect of IACC, but more importantly, because we are saving the eye, the question from a clinician point of view is that, have you removed all the cancer cells from the orbit? Have you left any cells behind in the orbit that can later on spawn in tumor recurrence? So we want to look at the margin of the mass that was removed to see if there are clues whether we left viable cells behind in the orbit or not. So here's a case that illustrates the clinical utility of apoptotic markers, how to help the clinician to follow this patient. First, this is a patient was presented with adenoid cystic carcinoma of the lacrimal gland using axial and coronal views, and after 2 cycles, you can see the reduction in the lesion itself. And this is the pre-IACC biopsy showing the typical morphology of adenoid cystic carcinoma. And then on the right, after 2 cycles, you can see there's a massive reduction in the tumor cells, but there are still some HE-positive adenoid cystic carcinoma cells there, but most is hyalinized and scar tissue. What I'm interested in is the resection margin, whether there are tumor cells behind or not. So using the tunnel assay, one of the 5 markers that we use, we can see that there are tunnel positive cells indicating these are apoptotic cells in the margin. So the inference in that, if we can use this as a surrogate information to say that if we had left any cells in the orbit, they are already undergoing apoptosis. So that's the utility of the information we gather from using this technique in here. Here's another section showing that there are apoptotic cells at the margin. So hopefully the cells that we inadvertently left behind in the orbit will undergo apoptosis. And then we develop a lacrimal gland cell culture to characterize the phenotype as well as the genotype, and it does parallel to that of the human tumor. The number 3 is develop a high throughput pharmacological screening using the cancer cells in the tissue culture and expose them to 100 FDA approved cancer drugs and see which drug will affect the cancer's the tumoricidal effect at the tissue level, and then using that to treat it in an animal model. And so the fourth tool that we use is using a severely immunocompromised mouse and injecting the patient's tumor cells into the peritoneum, and then let the mass grow. But interestingly enough, injection into the peritoneum leads to the disease, the recurrence of the adenoid cystic carcinoma in the lung. And so we can use this animal model to test the drugs that identify potential candidates identified by the pharmacological screening to use it in an animal model. By far the most important study that we have done is that the discovery of certain mutations, the main drivers of this cancer, using the exome sequencing of this number of patients that we have after treating with IACC. And the central driver of this turned out to be mutation in the Notch1 and Notch2 and 3, but also there are mutations in the mucin genes of which the significance is unclear. We need to define that, but clearly the discovery that Notch1, 2, and 3 are the main drivers in this. It's important because there are drugs under development now that's aimed at turning off the upstream mutation, and that is a Notch mutation in here. The significance of this finding is that the dysregulation in Notch signaling, it exerts an epithelial to mesenchymal transformation in cancer, is a major driver in cellular proliferation, cellular invasion, as well as drug resistance. And so we are working with the chemists now on a drug that will turn off this mutation as an upstream control rather than downstream regulation. And so this is exciting because of this discovery. But from a clinician point of view, we want to know why is it that the tumor is so difficult to treat, and to find out what is the escape mechanism of this tumor. And to do that, we look at proteinomic expression to identify the retreat mechanism of this cancer when they are assaulted by cisplatin. We identify that the fibroblast growth factor receptors are upregulated after challenge with cisplatin. And what's good about this is that there are drugs that we can inhibit this. And this is the migration assay combining cisplatin with a drug by AstraZeneca called AZD4547 in combination in this cell culture model, showing there's a noticeable inhibition of the cells using this combination, thus indicating that we could use this as an adjuvant therapy on top of the cisplatin treatment in here. And so with that information, here's an opportunity for one of the patients for treatment. He presented to us with a extensive lacrimal gland tumor, and then presented with a metastatic disease to the lung. And then we treated him with lenvatinib, which is the only available FGFR inhibitor. And you can see that with time, there is a reduction in the volume of the tumor after 3 months of therapy. So this is an important utilization of drugs available in the marketplace to enhance therapeutic index in here. So the take-home message for the adenoid cystic carcinoma is that the IACC-based globe-sparing strategy appears to be promising, but the efficacy of this treatment cannot be assured until we follow this patient for more than 10 years. And we have assembled a toolbox to look at the treatment effect, and also establish a lacrimal gland ACC cell line for every patient, and then develop a xenograft model to recapitulate the tumor, and then treat these use it to treat the candidate with candidate drugs. And we also develop an in vitro and in vivo protocol for testing drugs, and identify Notch 1, 2, and 3 as the key driver of this mutation. And then fibroblasts, the growth factor receptor upregulation is the target that we want to blunt the retreat mechanism of the cancer in overcoming drug resistance. So this is the helpful information. The other topic in which effective therapy remains elusive is traumatic optic neuropathy. I'm sure all of you are aware of the clinical presentation. One trauma to the orbit, no bony fracture, and the globe is intact, but the patient is blind, cannot see, and associated with an aberrant pupillary defect. The putative mechanism of injury is thought to be the shock wave propagating through the orbit, hitting the optic nerve, or affecting the fixed portion of the optic nerve at the annulus of sin, or perhaps there's a compression of the intracanalicular bone and expanding and causing the injury. And that starts a cascading sequence of molecular events leading to cellular demise of the retinal ganglion cell. We want to identify the molecular events leading to the cellular event. So aim for us is a neuroprotection. How do you stop, blunt the molecular events before the RGC begins to die? And so, unfortunately, we don't have a model for testing therapeutic options because the current mainstay of treatment is either observation, high-dose systemic steroid, or canal decompression, or combination of steroid and decompression. But we know from the prospective international optic nerve trauma study concluded that after adjustment for baseline visual acuity, no clear benefit of either corticosteroid therapy or optic canal decompression surgery was helpful. So neither the corticosteroids or optic canal decompression should be considered, that's a caution from the study, should be considered the standard of care for patients with traumatic optic neuropathy. In essence, we don't have a treatment for this condition. So to look for a treatment, we need to have a model. Unfortunately, the only model that we have is a crush model. Unfortunately, it doesn't simulate the clinical scenario because the nerve is not really crushed. So to develop an ideal animal model, it should approximate the clinical scenario is reproducible. It has objective parameters to assess the molecular events leading to RGC death, and then objective parameters to quantify the RGC as well as axonal loss, and to also to characterize the time course for the molecular event leading to the cellular event. So that's what an animal model is needed. So we have developed an external animal model using an ultrasound delivery system, and here is it's an instrument that we find in the lab to use to break down proteins and break down DNA for analysis. It's an instrument that we modify with a special 3mm tip that's applied to the orbital ridge corresponding to the entrance of the optic canal into the brain in a mouse model, and apply a 20 kilohertz single blast through the bone and traumatize the optic nerve. And then we look at the molecular events after the injury and looking at the pro-inflammatory cytokines and chemokines, and here are the cytokines at TNF and interleukin-1B, and then the chemokines is CCL1 and then the other. And then also the GFAP, which is an activated substrate that is in cells in macrophages as well as in the astrocytes, and essentially that's the indication of the cellular populations that it's involved in the injury. You can see that in this immunohistochemical study 24 hours after injury. You can see the profile of the TNF alpha